Uh, Thank you very much for your attention. Thank all of you. Thank the NCPF. I have a couple of comments, and it'll take a second if you guys just want to stay put. First of all, PDFs of the presentation and a video of today will be up on the website in a week or so. There will also be a summary report that'll take several months. But really appreciate the speakers. I have a couple of thoughts or really just observations from today. The first is to go back to Calypso's talk. I thought Ezra Klein's quote, which I hadn't seen before, was very trenchant, that we were paying a very high premium in the U.S. to avoid some conversations that other countries were willing to have about the goals of healthcare and will it fit in the budget as well. There was an abundant sense actually today, I thought, and it's just math, that drugs are a fraction of the spending in cancer. It's a small fraction. I don't think the follow-on comment was widely, or the follow-on thought of that, which was that therefore we don't need to worry about them, was exactly what followed from it, but nevertheless an important observation. There were quite a few solutions which seemed, at least in terms of their heuristics, to be attractive, value-based pricing, bundling, things like that, but it was clear that either because of philosophy or culture that those things would be difficult, and just the pure claims complexity side on transforming any of these things came across in a number of the talks. I was intrigued. Nobody all day pointed out that these prices are fictions, that they are not carved on stone tablets. In fact, most of the discussion around today, with the exception of the value-based pricing piece, assumed that the price was something that couldn't be changed, really, but that we just had to take it. But the follow-on of that, which I hadn't really thought through, was that at some level we are responsible for international drug pricing as well because of how we're addressing our prices, that there is a sense that the markets are moving together, although obviously with different multipliers. I was interested, I'm left with a question about site of care shift, and I don't know, there was a conflation to some extent, an intriguing one, between site of care change from the doc office, the hospital, and the sense that the market distribution or access was collapsing. Those are obviously part and parcel of the same thing, but they are not the same phenomenon necessarily. If docs are just flipping their name and everything else stays the same, that probably doesn't affect access. If there's essentially a collapse of the infrastructure towards centralized hospitals, that's a very different thing. And I didn't get a good quantitative sense of which of those two things was occurring. Another thing that I noticed was that, and I work at one of these obviously, and hospitals are doing really, really well right now. Things are very good for them. The reimbursement on their drugs is 2 to 3x what it is in the doc office. They're capitalizing on 340B at unprecedented rates. And they're not even here lobbying for themselves or making their case why that's important. That's how much heft they have in this space. So when I look at those numbers, I have to say I see a lot of fat in the system and a potential to move forward taking advantage of those things. But it is really an interesting phenomenon that is a big shift since from 10 years ago. I want to pick up on Patty's comment that there is always this sense of the other doctor who won't practice evidence-based medicine that the patient will go to, that, as Mark pointed out, will be there to harm the patient if you try to stop them from being harmed, essentially. And that is something we have to sort of wrap our hands around, or heads around. But anyway, those were my thoughts for the day. I really appreciate your coming. Thank you very much to our speakers and the other speakers who are still here, and enjoy the rest of your evening.